All right. Assalamu alaikum. Good morning, good afternoon, and good evening, depending on your time zone. I hope everybody is doing great. So today is our first day of physical examination class, and we're going to talk a little bit about what to expect on NACOSKI, physical examination stations, and let's start it. All right. So here, the goal today is to take you from A to Z, what to expect. But again, the most updated real life changes that Dr. Sef Fayaz experienced. He's going to share his experience and his feedback. Okay. So we're going to talk about a lot of stuff, but the most important things that we are going to touch based on is professionalism, the structure, patient comfort, correct sequences, clear verbalization. These are going to be the main topics that we are going to discuss it today. Focused how physical examination appears in the NACOSKI. What candidate should expect from the official MCC station design. Focus physical examination embedded in the clinical task. Uh, Sorry, I got a call. Uh, Sorry, I had to cut it. Uh, Dr. Sefayos, I think Dr. Sef Marcel wants to find the location if we can help her. Thank you. Uh, Dr. Sef Marcel. Okay. Uh, yeah, you have it? Thank you. So physical examination will come in a different format. So focused physical examination embedded in a clinical task, combined history, plus focused physical examination station, examination followed by interpretation of findings. For example, they might give you a scenario about someone, and then they give you the x-ray, and then based on the x-ray, you need to perform the physical examination. Okay. Examination followed by management or next step. You do the physical examination, and based on your finding and also the scenario that you have, based on all those clinical findings, then what is your next step and the management. Assessment of professionalism, sequences, comfort, and closure throughout the station. Okay. Uh, Now, what examiners are looking for? So if you are attempting the real exam, let's say you're a candidate. So what actually the examiner needs or expect from you beside your knowledge? Remember that NAC-OSCE is not 100% knowledge based. Dr. Said, you can sit beside her and share the screen. So professional introduction and confirmation of the patient identity. So it might look very minor to us, like it's okay, it is a minor mistake. I forgot to introduce myself. It's a minor thing. It is not a minor thing. It costs you a lot of mark. Let's say if it is 5 out of 5, you lose 5 mark. Confirmation of patient identity is super important. So if you enter to the station and you do not ID that station, trust me that you lose a very big chunk of score. Clear explanation of the examination and valid consent. So why you are here? You need to explain, I'm here to perform physical examination so that you prepare the patient for some sort of maneuvers, so that the patient should expect you to touch her, to feel her, and perform some physical examination. So the patient is mentally and physically ready for it. And valid consent. So we cannot touch the patient without her consent. Regardless of the first consent that we have as a general consent at the beginning, every single time that we are touching the patient, especially if it is a sensitive area like face, like eye, for example, or anywhere close to the private area or anywhere close to the chest, especially if it's a female, we need to ask for a consent separately. The first one is like a general consent. Then the second one is based on every touch. Before we touch the patient, we need to refresh our consent. Hand hygiene, comfort, privacy, like you need to comfort the patient. Like I'm going to do or I'm going to perform this and that. And during the physical examination, you might feel that I'm touching your body or feeling your body. But if you feel at any point that you cannot take it, or if it is discomfort for you, or it is painful, please let me know and I will stop it right away. So when you're explaining your rule, that this is what you're tasked to do, also provide the patient with that information that these maneuvers might be a little bit uncomfortable. But if you feel that it's going to be uncomfortable or it is painful, please let me know and I will stop right away. So you have to provide this privacy. Always make sure that you respect the patient's privacy. If if it is an ethical condition station that you need to, let's say, talk about or take a history or do a consultation, you need to ask the patient, let the patient know that everything that you are providing for the patient or the patient is providing for you, it's going to be kept confidential unless the patient wants it or it is asked by the law. So the patient has to kind of open up and has to trust you so that he can give you everything you need. And it's going to be a win-win situation. The station is going to move very smoothly. And also the patient will give you everything because he is or she is trusting you because you have already provided her or him with a confidentiality. And correct exposure. This is also very important that when you are examining the patient, you need to have the area that you're, let's say, auscultating, it has to be exposed in a proper way, not to uh, less expose it or too much expose it, that you expose the private area, or you expose it in a way that you are able to perform your physical examination while you are respecting the or protecting the area that's not supposed to be exposed. Orderly techniques. This is very important that we need to have a structure. Before you enter to the station, if you have the structure and you enter that station, you will 100% will pass the exam or that station. If you just say, oh, this is depression, okay, let's go. And then without having a proper structure, without having a short note, and if you enter, trust me, you're going to be all over the place. You will do that station, but you will be very disorganized. And if you are disorganized, it's going to give the examiner very hard to score you. And when it gives the examiner a hard time to score you, guess what happens? You lose mark, right? So it's always good to have a structure. That 2 minute is very vital. Do not take that 2 minutes for granted. So that 2 minutes is not just to read the scenario. Like a few seconds, maybe 30 seconds is just to read the scenario, but the rest of it, like 1 minute and 30 seconds is how should I start it? And how should I finish it? I'm going to introduce myself. I'm going to confirm the patient ID. I'm going to take the consent. And then I'm going to start the OCD PQRST. And then I'm going to do the review of the system. Then I'm going to do constitutional sign and symptom. Then I'm going to do a transition to the past medical history. Then I'm going to transition to the family history. Then I'm going to do a transition to the history part. And then I'm going to summarize it. Now this is a structure. You did it. It didn't even take you 1 minute. So you did this structure into within 30 seconds or 1 minute. Now you're prepared, then go. Because this is how the examiner is, the checklist of the examiner scoring is designed based on that structure. So if you do, he keeps on tick marking. But let's say you do one here and then one 2-3 pages later, then the examiner has to go and turn the page in page 4 and then give you a mark or a tick mark. So this is going to give the examiner a very hard time. When you are not structured, so guess what? The examiner, instead of giving you 5, he's going to give you 3 because you gave him hard time, right? So try to be very structured and very organized, do everything in an orderly fashion with the relevant sequences and comparison of sites. So when you're providing or performing physical examination, always start in a very orderly fashion. And also you have to compare each side at the same time when you're doing it, or at least verbalize it. For example, when you're checking the left knee, then you, for example, you're touching it or you're palpating, I'm going to compare it with the right side. They will say, skip, skip, skip. You don't have to do it, just verbalize it. As long as the examiner knows that you are kind of checking both sides. Gentle handling and awareness of the pain. So we need to be very gentle and we have to have awareness of the pain. And this is respect to the patient. If the patient says that I have pain and you disregard the pain or you just dismiss the pain, that shows that you're not professional. Purposeful, gentle inspection before touching the patient. So we have 2 types of inspection. One is general, one is focused. So the general is, this is what examiner wants you not to miss, that you have to do the general inspection before you do the focused inspection. So what's the difference? The difference is that when you do the general inspection, you have to be standing at the end of the bed and do the whole inspection overall from head to toe. How the patient looks like, how the patient sit, is the patient is under a lot of stress? Does my patient conscious? Is my patient conscious? Is my patient unconscious? Is the patient is breathing too fast, too slow, or the patient looks pale or yellowish or bluish, whatever. So these are all our broken arm, or can you see anything like an aid, walk aid, anything like a wheelchair, or if the patient is connected to IV or not. So these are the general inspection. Then you go ahead and do the focus inspection, which is, for example, if that's the thyroid, then that is the focus. You go directly to that area. And focus examination rather than random maneuvers. I did mention this, accurate verbalization of findings. So again, with everything we find in a physical examination, it doesn't mean that the examiner knows that you found it, verbalize it. For example, when you see dislocation, or for example, a cat, I find this cat in this area. So the examiner doesn't know that you know it, so it means that you have to verbalize all your finding. That this part is, for example, the pass on the right side is strong, on the left side it is weak. Okay, so you have to verbalize it. Logical interpretation and transition to the next step. The interpretation has to be very logical and transition to the next step supposed to be the way I told you guys many times when we were doing the station, that we need to be very professional, and always when we're doing the transition, we have to refresh the concept as well. Proper closure, time, cover, and summarize. Do not forget summarize. Canadian opening sequences. So from A to Z, what are the basic stuff that we need to know? Knocking, enter, greet, introduce yourself, confirm the patient full name and date of birth, state your role and role clearly. Why are you here? Are you taking history? Are you taking consultation, doing consultation, or are you performing physical examination? Right? Explain the purpose of the focus examination. Ask for the consent before touching the patient. Always, before touching the patient, we have to refresh our consent. Offer comfort measures and chaperone when relevant, which I doubt it if they give you any nurse or someone who can assist you. Position and exposure appropriately before you begin. I will show you how to expose a patient properly in a professional manner. So the model script is, for example, This is an example, but you can do it in your own way. Hello, my name is Dr. Muhammad Nasir Jola. I'm one of the candidates today. I'm one of the doctors in the ward today. I'm one of the physicians in this ward today. Whatever you put it, however you put it. Can I confirm your full name and date of birth? I would like to perform a focused physical examination to assess your condition. I will explain each step as I go, and if you have pain or want me to stop, please let me know and I will stop right away. Is that okay? And the patient say yes. So do not miss, no touching before consent, never. No exam without adequate exposure and patient comfort. So patient comfort is very important. Very important. So do not put your patient in a position that's uncomfortable for patient for various reasons. Two obvious reason is that if the patient is in an uncomfortable position, whatever finding you find is not accurate. So if the patient is in an uncomfortable position, the patient is not going to be supportive. So these two will lead to unhealthy approach. Seats, TTCE and IPPA. So basically for the seats, this is now focused. So the general I told you, what do we do? From head to toe, everything we find. My patient is sitting on the edge of the bed. The patient looks pale. The patient looks fine. The patient looks confused. The patient looks jaundiced. The patient is in an excruciating pain. The patient has no pain. The patient is comfortable. I don't see an abnormality. I don't see any wheelchair, or the patient is not connected to oxygen or not connected to the IV line. So these are general. Now focus. Let's say if you are doing a focus inspection or of the knee. So remember, for any focus, remember SEADS, SEADS, symmetry, exposure, attitude or appearance, or we can say atrophy, deformity, swelling, skin change. Okay? For the TTCE, talk to the patient, touch properly, compare both sides, exposure adequately. IPPA, an inspection, palpation, percussion, auscultation. Obviously, it's going to be different from system to system. For respiratory, we do an inspection, palpation, percussion, auscultation. For abdominal, we usually start with an inspection, auscultation, percussion, and palpation. For for musculoskeletal, look, feel, move, special taste, and neurovascular status. For the vital signs, I'm not going to waste your time on this. Basically, most likely vital sign will be given because they're not going to waste your time on doing the vital sign. It is too basic. It is not for the IMGs. Usually they will provide you, but what if it is not provided? We never start any physical examination if we don't have the vital sign. So let's say you have a back pain, right? You have a back pain station. You enter to the station. The first thing before you perform is that I need the vital sign. And if the patient has an abnormal vital sign, the examiner will tell you the patient has hypertension. The patient oxygen is this and that, or the temperature is this and that. But if it is normal, the examiner will tell you it is normal. Okay? They're not going to ask you to do the most likely. So you never know, but most likely 99% of the time, they're not going to ask you to perform doing vital signs. They usually provide you. Either it is going to be on the instruction behind the door, or if it is not, please do not forget to ask that I will start my physical examination by doing the vital sign, and the examiner will tell you, don't worry, skip it, everything is normal. End of the bed inspection. This is the general inspection, okay? Your patient is lying down, sitting. You need to stand right in front of him where you can have a very good view of the patient from every different direction. Then you do the general inspection. The stress, breathing pattern, posture, alertness, body habitus, mobility aids. If the patient has any mobility aids, oxygen, IV lines, scars, anything that you see as a general inspection. Then visible clues, pallor, jaundice, cyanosis, dehydration, sweating, tremor, edema, cachectic, confusion. Verbalize what you see before moving into focus examination. So on general inspection, how do you use a phrasing of doing a physical general inspection? So on general inspection, the patient appears comfortable, at rest, is speaking in a full sentence, and does not appear pale, cyanotic, or jaundiced. Teaching cues, and inspect first, touch second, and we never touch without consent. Okay. General principle across all the system: hand wash and state hand hygiene clearly. So if there is, which Dr. Cephayos will tell you, that if there is any hand sanitizer nowadays there that you can use, if it is not, just mention it. Let's say you enter to the station, there's no hand sanitizer, or you can actually, you cannot locate it, you can't find it. So at least mention that I'm going to use the hand sanitizer before I touch the patient. Okay. Position the patient properly for the system being examined. Expose only what is needed while preserving the dignity of the patient. Inspect before palpation. Start away from pain if the patient is tended. So we never start from the location or the part where the patient is having pain. We start away, then we make our way close to the patient area that's painful. Compare both sides when relevant. Move from general findings to focus finding. Thank the patient, ensure comfortable and close professionally. Remember that when the ring goes off, the bell goes off, we have to leave. But it doesn't mean that we have to leave the patient hanging or exposed or unfinished, right? So for example, you expose the patient chest, you're auscultating, the bell goes off. We have to stop right away. We cannot even say one more word, but we can say thank you. Thank you very much for being very helpful and supportive. Cover the patient, help the patient to sit down, the same position that you started with, then leave. So you can't just leave because the ring goes off or the bell goes off. Now my job is done here and just leave. Trust me, it will cost you a lot of score. So be professional. That few seconds, you have to cover the patient. Your job is not done unless the patient is in the same position that you found the patient. If the patient was sitting, the patient should be in that position when you leave. Okay? So cover the patient, thank the examiner, then leave. Be very nice and professional. So faculty language: be calm, gentle, deliberate, organized. It should looks like that when you are teaching a class, when you're performing a physical examination, you should look like a faculty, like a professor. You have to be very calm, very quiet, very organized. Exam trap: random maneuver without context, look unsafe, and score poorly. Okay. Expected finish: thank you. I would ensure the patient is comfortable and then summarize my finding. Okay. This is what you're saying to the examiner. Live demonstration: we have to now do some demonstration, which in this case, we will ask some of you to do it here. And the common mistakes that you do not want to do. When we say common mistakes, it means most of the IMG has already made this mistakes, and we are trying to pinpoint that and avoid it. Okay? Touch the patient before consent. Please don't do it. No hand hygiene statement. If there is hand hygiene, hand sanitizer, please do it. If there is no hand sanitizer, just mention. Okay? Poor exposure or no attention to privacy. Please be very respectful. I would say, how do you want to be treated if you're a patient? Treat the patient the way you want to be treated. Before doing anything, let the patient know this is going to happen. For example, you put your stethoscope in the patient's chest. It might be cold. Let the patient know, because I would be surprised and I would be shocked if somebody touches something in my skin and it's super cold. I would hate that, right? But if he tells me that this is going to be cold, I would expect it and I would respect it because he has already given me a heads up, right? So I would say treat the patient as you want it to be treated, like a professional. If you have a doctor who is professional, nice to you, kind to you, at the end of the day, when you leave, you say, thank you very much. It was an amazing experience. This is how you should be with your patients. So jumping between unrelated steps, please do not be all over the place. Be structured. No general inspection. Do not forget, always start with general inspection. No comparison of site. I know we are going to get overwhelmed when we are in the station, but always remember that if you're performing a physical examination on the left side, always compare with the right side. You will not be able to tell the difference if you're not comparing it. So failure to ask about pain before you start, about the comfort of the patient, if the patient is comfortable. We never start our physical examination unless we are 100% sure that the patient is comfortable and ready. Okay? Weak or absent closure. Always close the station with very strong, very strong. These were this is my patient. Patient came with a back pain. I performed these physical examination, and this is my finding. Then leave. Okay? With a thank you, very respectfully, leave. Mumbling findings instead of speaking clearly to the examiner. Please do not mumble. I know sometimes we think that these are basic stuff. Everybody knows it. Do not think that the examiner knows it. The examiner knows that, but he wants to expect you to verbalize it. His job is to hear and mark you. If he cannot understand you, he cannot give you score, right? And we cannot blame him. So we have to be very clear so that he can understand us and he can score us for it. Okay? All right. All right, so these are the things that we need to do. I'm gonna jump. So high yield teaching purse, introduction, these things we mentioned. A structured candidate score better than unstructured candidate with a good knowledge. So this one, I made it red and bold. And the reason I made it red and bold, because remember in NACOSK, it's only 30% knowledge. 70% is how you behave, how you communicate. Are you patient-centered? Are you safe to be in a station? Because sometimes we are going with one condition. After we visit the doctor, we come back with two different conditions. For example, I have a back pain, but the physician was not very safe. He caused me another condition. Now I have neck pain because of wrong maneuver or being so rough with me, right? And one more thing, when we are practicing here, just a heads up, none of us are patient. We are going to be a standardized patient. So we are going to help each other out. So be very gentle. And same thing applies in the real exam. Those standardized patients are a standardized patient. They are not real patient. So be gentle with them. As long as you show the examiner, this is how it's supposed to be done, that's good enough. They're acting, you're supposed to act. Like a Sperling test. If you put too much pressure on somebody's head to find out if the patient actually have a Sperling test positive, trust me, the patient at the end of the day, after those maneuvers, will have a neck pain. And when you leave the station, the standardized patient has a say in how you performed. Like, for example, let's say you did a back exam, you leave. Now you have 2 minutes to go to the other station, read the instruction. And there is one more candidate who is in the same station, standing behind the door, and he is getting ready for this station. This is the time that the examiner is communicating with the standardized patient. How did he do? And if the standardized patient said, you know what, he was very rough, very unprofessional, and he hurt my neck, regardless of what you have done the whole station, you will fail that station. If it was 90, 80, if you hurt the standardized patient, you will fail that station. Be careful, please. This is very important to be very gentle. Do not be rough and just act because they're acting. We need to act, but we have to act very professionally. A student must practice uh, out loud and speak fluently. And the tone, please, if you are dealing with tragic condition, abuse, your tone has to be lower based on that station. If you're dealing with something very excited, for example, someone is here just to do a consultation how to do breastfeeding. So this is a good news. She is very excited. There's nothing wrong. She just want to know how to do the breastfeeding. Now the tone should be a little bit based on that station, a little bit upper, right? So, and you have to be very enthusiastic. But if somebody who just had an attempt, suicide attempt, now for that, how you can adjust your tone and posture, that's different. So we have to keep everything in balance. All right. So these are the references, and thank you very much. So I'm going to stop here, and I ask Dr. Seth Fayos to give you guys a little bit orientation on what you need to expect in real exam NACOSCI. I'm going to stop here, and he's going to start the recording again, okay? I know.